Thank you for coming today. So good evening, good afternoon, or good morning, wherever you are. My name is Elsara Bedri, and on behalf of the Global Alliance on War, Conflict and Health, I welcome you and thank you for attending today. Before we start our session for today, I just want to say a few words about the Alliance or about the Global Alliance on War, Conflict and Health. We actually formally launched via an online event in the summer of 2022. We currently have more than 100 member organizations from different institutions, academia, humanitarian organizations, and journal. For those who want to learn more about us, and I encourage you, please, to go visit our website. You can find information on how to join us. We also would like to expand our working groups. We actually had a successful experiment or experience last year with a thematic working group that formulated our knowledge resource portal. We currently are seeking volunteers to update it. I've actually reached out to a few already, and I thank those who have responded and who are here today. If you do want to get involved with any of our activities, please go to our website and hit the button of how you can get involved. You can also get involved by becoming a member or volunteering. We also welcome suggestions. If you have any ideas for thematic or geographic or any type of working group ideas that you have, so please share them with us and we would love to collaborate with you. This is our sixth webinar in the series. Previous webinars that we had explored topics such as explosive events in urban areas, health system in the context of war in Ukraine, the US footprint in wars in Africa, the long legacy of nuclear weapons production and testing, and the lingering health harms that come from that. A case study was the Marshall Islands. Our last session looked at the effects of war through a public health lens. Of course, you can also find all of these recordings on our website, and we also have a YouTube channel that you can follow. Before we start our session today and I hand over to our speakers, I'd like to thank a few people who made this webinar series possible and today's possible. So in addition to of course, to Hashim and Mohammed. Becky Brown with Southampton University, Amy Hagopian, who is a professor emeritus, who is also the co-chair of the Alliance. Stephanie Endo, who has made this series happen. She's really been the one doing all the work behind the scenes. She's an MA and MPH student at George Washington University. I'd also like to thank Dr. Samer Jabbour, who is co-chair and a founding member of the Alliance, as well as Professor James Batchelor, who is also co-chair of the Alliance. It is worth noting that the University of Southampton serves as the current host of our Alliance Secretariat and has been serving in this capacity, hosting our Secretariat, our Alliance Secretariat since our launch in July of 2022. We are very grateful to our speakers today. They accepted our invitation to present about the war and health in Sudan. I just go on now to introduce them. Hashim Ibn Auf is a transportation consultant and an architecture expert. He held the position of Federal Minister in the Ministry of Infrastructure and Transport during the civilian government in Sudan. He worked as the station's architectural manager in Qatar Rail Company. He also previously worked as a senior design architect at King Faisal Specialist Hospital. He was an adjunct assistant professor at Columbia University and taught at Manhattan campus of Pratt Institute of Technology. Mr. Ibn Auf is a graduate of the Faculty of Engineering at Khartoum University and holds a Master of Engineering from Stevens Institute of Technology. Our second speaker is Mohammed Al-Mahan. He holds a Bachelor of Medicine, Bachelor of Surgery from the University of Khartoum and is the Director of of Humanitarian Relief at the Sudanese American Medical Association, SAMA. Since the start of the war, Dr. Al-Mahal has been involved in managing SAMA's urgent humanitarian interventions in Sudan, with a special focus on fundraising and donor management. It's also worth noting that Muhammad Al-Mahal still has family in Sudan. He works out of Cairo at the moment. We wish them all well. So before I hand over the floor to them, I would like to say that we are holding this meeting as a webinar. Unfortunately, there is no really contact between us in terms of audio and video. It's only a one-way direction, unfortunately, from the presenters and the panelists to the audience. But if you do have any questions, please write them in the Q&A box and we will get to them at the end of the session. Thank you very much for being with us today, and I hand the floor over to Hashim. Thank you.
Thank you very much. Thank you very much, Sarah, and all of you, Global Alliance. I will start sharing my screen. You can see the screen, right? So Sudan, I have been out from Sudan since a very long time. And at the time of the war, I was in Qatar, working in Qatar Railways. Till now, I continued and resumed working there. At the time of the war, I actually had experienced a very harsh fact that my brother has been stabbed on the 10th day of the war, on the 25th of April. And with that start, my journey began as to experience how the actual experience on the ground was in Khartoum and in Medani, the closest city to Khartoum. Before going to into this journey, I want to play this video, which will continue for about 2 to 3 minutes, about Sudan, to get familiar with who are we and what is Sudan. All right. It's really, I mean, every time I see this video, I just get chills, you know. This has been done in the first year of the civil government in Sudan in 2019 after the revolution. Correct me if I'm wrong, Al-Mahal. And I remember it now because Al-Mahal helped me in this video and he suggested it. I remembered it now. It was being prepared by the government of the civil government, which I was part of it. I was privileged to be part of the first year uh, after the revolution. I have spent 47 days in Sudan after I heard the loss of my brother. And in April 25th, 10 days of the war, I started my journey from uh, from Qatar to Sudan. And at that time, no airport was working. So I have to go through Ethiopia. This is a photo of my brother when he was working in Sudan in his clinic. And so the journey started from Doha all the way to Addis Ababa to Gondar, the uh, local airport, and then by land all the way to Medani to pick my parents from Khartoum, from the deep inside the heart of the war, back to Medani. All the photos that appear on the right-hand side is real photos coming from my journey during that trip, which was filled with sadness, of course, and sense of responsibility towards my parents and my sick brother, older brother, after the loss of my the main handhold of the house. I had also to travel all the way to Cairo to send my elder brother who was sick to a place of care, and I have to come back afterwards to Medani to have the second trip to get my parents out because my father was on dialysis and it was extremely difficult to find a regular dialysis in Medani. And this will be reflected later about what was the size of damage to the healthcare sector in Sudan after the war. Just for a glance, for people who are not familiar with Sudan at all, maybe only that it is at the heart of Africa, south of Egypt, but it's actually 70 times bigger than Palestine, which is 27,000 square meters. I'm mentioning Palestine specifically because of the proper, I believe, the proper media that is sending real time reporting uh, on the crisis over there, which is not happening equally in Sudan. So there is a loss of awareness about what is happening in Sudan. And this is what I'm trying now to do in Al-Mahal and Global Alliance is to reflect into what is happening there. Sudan, if we compare it with Gaza, what's happening in Gaza? Gaza has 1.9 million internally displaced within Gaza Strip. And there is up to today 31,000 or 31,000 fatalities, 73,000 injuries, and so on. You will see now, when you compare with Sudan, that the internally displaced in Sudan is reaching 7.5 million. So the context before the 15th of April, before the war in Sudan, is we have a population of 46, almost 47 million. 20% are urban and 70% are rural. And the most of the population is in Khartoum, where the war has started. And you will find out in the numbers that out of this, about 9 to 10 million, 3.5 million has displaced from Khartoum. As you have seen from the video, you have realized how big Sudan and how diverse is Sudan. The country hosts estimated 800,000 also South Sudanese refugees before the war, 330,000 of refugees and asylum seekers from Eritrea, Syria, Ethiopia, Chad, and Yemen. So the country was already having these camps of refugees. 30% of the population at that time before the war needs humanitarian assistance. 3 billion IDPs and 1.16 million refugees. So with this burden over this population of refugees and humanitarian needs, uh, you have also to understand at time of emergencies, you have a very big demographic spread. You have geographical difficulties, especially in the time of rain and with the heat on the vast areas of desert, poverty, and poorly managed decentralization system. It is all becoming a burden of how to manage this country. The context after the 15th of April uh, totally pushed the country into uh, the edge of starvation, into the edge of disease and epidemics. The spread of the war was since April to today is about 11 months. It started in Ramadan, and now we have reaching the beginning of Ramadan, and the war is continuous. The photos here are showing the presidential palace at the top and one of the houses at the bottom. Every place in Sudan has been a war zone. The red, this is the war map. The red represents the national army, the Sudanese armed forces, and the yellow is represented the rapid support forces known as Janjaweed. And they are being called as rebels because this and they have been actually before 15th of April representing the armed forces of Sudan. Uh, and the green and the other colors are actually other rebel armed forces that have been there for very long time, maybe tens of years, asking for equal opportunities in different aspects, education and health and so on. In a statistical look, as I mentioned before, 7 million, and this is the largest internal displacement crisis worldwide. And everybody will be surprised how come a largest internal displacement in the world today is not being reflected and the awareness is so minimum. 2 million are externally displaced. Now, I think every family you ask in the outside of Sudan, they will mention to you where part of his family is in Egypt, the other part in Saudi Arabia, the other child immigrated to Canada, and so on, all within this 11 months. We have 15,000 fatalities, 33,000 injuries up to today. The needs are medicals, medicines, hygiene kits, mattresses, beds, water wells, uh, tarpaulins, food, baby fits, kitchen set. All of this is a big need today. This is the latest displaced individuals map, and you can see clearly on the line of the Nile, uh, all the way down and all the way spreading west and east in the southern part of Sudan. And taking a look at the west part where we have West Darfur and Central Darfur, this is the highest immigration to Chad. Chad has now is became the shelter for 700,000 individuals from Sudan, and this is where the biggest a challenge for the humanitarian organization to feed these people. They are actually dying day by day, especially the children under 5. Uh, I had a similar presentation months ago in January, and look at the figures jumped from 500,000 to 700,000 in Chad. This tells you that the war is still fierce. After 11 months of conflict, more than 50% of the population, uh, about 25 million people need humanitarian assistance and protection. 1.9 million people flee across Sudan borders to countries already hosting large refugee population. And their situation is really bad. Some of them are on the floors. All families are outside in the streets. This is an infographic showing the percentage of the cities, states of Sudan, Khartoum being the capital state, 3.5 million, South Darfur, almost 1 million, half a million in North Darfur, and so on. The most recent one is Al Jazeera, which comes in the fourth place. This is the 2-hour drive state under Khartoum, in the south of Khartoum, where it had been the hub for healthcare for all the people coming from Khartoum for around 6 months until, or 7 months until uh, the rebels, Janjaweed, came and invaded Al Jazeera, killing one of the pillars of healthcare after the war. About 9 million, I said, have been displaced, and we have 3.5 to 60 million people have insufficient food. And uh, in a nutshell, as I am summarizing uh, these findings, we have inadequate health uh, facilities, and the spread of these diseases remain the means of an increase in preventable deaths. 60% of the country medical services uh, was being provided by Khartoum, and this has stopped completely and closed indefinitely. 70 to 80% across the country of hospitals are now out of service. Patients with kidney failure across Sudan, and I have experienced this for 7 weeks while I was traveling with, accompanying my father to the dialysis center in Madani. They have, just to give you an example, they used to have 2 shifts per day, 4 hours per session. After the war, it turned to 5 shifts per day with 2.5 hours per person, just to accommodate all these people. And the people will be in the corridors, outside the hospital. It is really, and after 7 weeks, I said, this is not sustainable. I have to take my father out. And this is what happened. But you'll find a patient with kidney failure across Sudan have faced unnecessary death. And this is the harsh reality. Cholera has been also spreading. There is at least 10,700 cases, including 292 associated deaths. 330,000 women are being expected to give birth by the end of 2023. And this is continuous challenge for families in Sudan. Food security remains the highest priority need. And I mentioned that the children under 5, 3.4 million of them, out of them 690 are severely malnourished. I want to jump to the next slide, talking about this website from the United States, from the United Nations in 12th of March, where they have mentioned here in bold, I have just highlighted the World Food Program announced operation on Tuesday and warned that life-saving programs in Chad will stop because of a funding crunch in a matter of weeks. This is happening now. We are witnessing this now, and I'm not sure why the funds is a problem. I thought of maybe risk, security, mobilization, but the fund to be a problem of feeding people, this is just surprising. People are right. Look at this photo. This lady with the kids are eating grasshoppers as their main meal. The actions that has been done by the NGOs is really great. The Sudanese NGOs has worked a lot, and maybe this is a segue to introduce Al-Nahal. Sama has been one of the principal organizations working in the healthcare. We have in Qatar, we have this engineering association. In Qatar, we have give a lot of projects and workshops and real initiatives inside Sudan, putting 3 priorities: emergency crisis management to preserve life, and safety and logistics, including shelter and mobility. Communication is a big thing that we are doing now, and today is one of them, is to raise this awareness. Of course, the most vulnerable are children and women, and electricity, fuel, and internet are the most have the most impact on population. All of these things and projects that we want to work on have been since April, and there is one website that the Association of Engineers in Qatar is doing to integrate all these efforts in one platform, so that even fund funders can find a place where they can find information, reliable information, reliable NGOs to work on that. So we have used even spatial decision support system populating in GIS format, visual statistics to help us intervene properly and with optimized resources. Uh, the operational challenges are really great, and I want now to hand it to Al-Mahal if you want and continue on this, because the topic of Sudan can continue for a very long time. Al-Mahal, please, you can unmute yourself and start your presentation.
Thank you very much, Mr. Hashim, for this comprehensive presentation and laying down the scene for the participants. Thank you also for the Global Alliance on War, Conflict and Health for providing us this opportunity to talk about Sudan and maybe shed light on things that the media haven't shed light on before. I'll first provide some background about SAMA, Sudanese American Medical Association, and then I'll give information about war and health. I think Mr. Hashim have covered this pretty well. Then I'll provide some insights about humanitarian challenges in Sudan and about the localization of aid model that we've been using. And finally, I'll reflect on our experience in Sudan. So SAMA is the Sudanese American Medical Association. It's a Sudanese diaspora organization that established in 2008 in the United States. And we have offices in Sudan since 2017. Our role is mainly leveraging donations of funds, medical supplies, and services from the United States and worldwide to improve the livelihood of our kindred in Sudan. So our mission is to improve the health and well-being of our communities through services, capacity building, and education and research. And our vision is to advance medical knowledge, develop and maintain the highest professional and ethical standards of medical practice and healthcare through scientific education and charitable initiatives. So those are some domains that Mr. Hashim already talked about. The war had a very devastating impact on the health in Sudan. And I've summarized all of the points into 5 domains: the health infrastructure, including the health facilities. As you may know, all of the health care services in Sudan are centralized in Khartoum prior to the war. So having the war in Khartoum exactly was a very problematic in this, as the other states in Sudan lack the proper healthcare services.
For some reason, okay, there was a pause for some.
Is it clear now?
Yes.
Okay. So yeah, I've said that all of the healthcare services was centralized in Khartoum, and having a war in Khartoum was very problematic in the healthcare system. The second thing is service delivery, including that lack of accessibility of the internally displaced people to have even basic life care saving medications and services. The third thing is medications and the supply chain. It has been very problematic importing medications into Sudan and distributing those medicines into the war active zones, including Khartoum and Jazeera. Also, the fourth thing is human resources. There has been a very a devastating lack of staff and medical professionals in Sudan because those medical professionals have fled their homes into other countries. and this created a very bad lack of expertise in the hospitals in the remaining hospitals in Sudan. The fifth domain is communication or coordination. The war resulted in a very devastating lack of communication at different levels of healthcare and governmental levels. So this also have been reflected negatively on the healthcare delivery in Sudan. Regarding the challenges of humanitarian aid, the first one is security. There has been no safe corridors for the humanitarian aid to be delivered into those in need. And it has been reported by WHO that even attacks have been imposed on the humanitarian care workers in Sudan during the war. So this has been very problematic. The second thing is bureaucratic obstacles. There has been a problem in obtaining visa for the international organizations, for their doctors and healthcare professionals to enter Sudan. And this have compromised the health care and the humanitarian aid delivery to the people in need. The second thing is importing supplies. The government have put the very restraining regulations regarding importing supplies to Sudan, and it restricted all of the supplies to come through the Port Sudan, and have prevented any other ways of importing supplies into Sudan. So this have been a problem. The third thing is moving aid within the country. As I've said, the RSF and armed forces haven't made a very safe routes for those supplies to go into Khartoum, for example, or into Jazeera, the areas where the war is still active. A third problem is internet blackout. This has been recent in Sudan for the past 2 months. There is no reliable internet in all of the Sudan states. It has recently been improved. Some of the internet network have returned into operation, but still we have a problem in connecting into people into the ground who we used to transfer them funds through applications which depends on having a reliable internet. The fourth thing is funding gap. Sudan haven't been receiving the same attention regarding funding as Ukraine or Gaza. We have returned into the comparison, but there is a real funding gap regarding funds to Sudan. As a solution for those problems, accessibility, the security, all of the diaspora and international organizations have shifted into the localization of aid model. And this model have really solved part of those problems regarding delivery of aid to Sudan. So localization of aid mainly is through empowering local actors in Sudan to deliver humanitarian aid to their local communities. So it utilizes local hands so as to provide aid for themselves. And those include local organizations, local initiatives, emergency response rooms in Sudan, and also public health sector. So what is the role of the local responders versus the international NGOs in this model? Local responders assess the local needs, and they have all of the tools to do this because they are already part of the community, and they have the knowledge, the necessary knowledge to assess the problems in the local community. So they assess the needs, they design the intervention, and this intervention are tailored to the local community regarding culturally or They know how exactly they can solve their problems. They also implement the project, the humanitarian aid project, and they do regular reporting about their implementation. The role of the international NGOs, so now the international NGOs don't have to worry about implementation or having to design the intervention. They just have to focus on funding and also on capacity building of those local responders. So now we have solved the problem of the accessibility. We have solved, we have this model which provided a really fast response in this rapidly changing situation in Sudan. So in this point, I wanted to shed light on the role of the Sudanese diaspora organizations who can work as a link between the large international funders such as USAID or UKAID and the local responders. So Sudanese diaspora organization can raise awareness about the humanitarian crisis in Sudan, and this could be through various channels, and also educate the international community and policymakers about the situation on the ground. They have the role in fundraising, and they can move quickly on this faster than the other larger international funders. They can mobilize their network so as to raise funds for Sudan. They have a role in advocacy, and they have a role in capacity building because they have the necessary knowledge and skills, and they can transfer those knowledge and expertise into the local responders. And so their main role is to bridge the gap between the international community and the local responders. So again, this model provided a rapid response, accessibility to areas that we haven't had been accessible to before because of the war. Adaptability of the humanitarian aid, because now local responders can provide a minute-by-minute report about the situation on the ground. So we tailor our humanitarian project according to it. It is cost-effective. Now we don't have to hire a project manager to hire staff. We can just use the local hands to provide the humanitarian aid. It is culturally sensitive. We can provide humanitarian aid that is culturally tailored to the community, and it is sustainable. And this is mainly through building the capacities of those organizations so as to provide a sustainable aid into the future. The challenges into this is accountability regarding the local organizations. It is hard to find local partners who are reliable and who can be accountable to what they do. Reporting is a problem because those local organizations have to provide regular reporting of their projects, and sometimes they lack the basic knowledge about how to report, and even the quality of the report, most of the time it's poor. So this has been a problem. Transfer of funds and also the SDG exchange rate have been problematic during the last maybe 3 and 4 months. The SDG rate in Sudan have been changing, and this caused a problem regarding reporting to the donors how much they donated and how much we spent on Sudan, because it changes every day. It changes day by day. So this is a problem. SAMA has created Dr. Busha Mnaouf Center for Learning in Port Sudan. And we use this Center for Learning in expressing this localization of aid model. So the Center for Learning in Port Sudan is equipped by internet and equipped by reliable source of electricity. And we have been hosting local organizations into it so as to train them and also provide a platform for them to meet with international actors so as to ask for funding or ask for capacity building workshops. So the center have really aided into acting as a link between those local responders and the international community. Those are part of the pictures of our aid in Sudan. This is one of the local partners in Sudan. We are all various organizations who we work with for a long time in feeding this place in Sudan. So as you can see, those are boys in the IDP centers, boys and girls in the IDP centers asking for food. And those are the volunteers of We Are All Values who we provided funding to, and then they implement the feeding project in the IDP centers in the White Nile state in Sudan. So this is an example of the localization of aid model. This is a virtual program, Trauma Echo program. We use this program to link global expertise of subject matter experts with surgeons on the ground. And this is also, I view it as an example of localization of aid. But here the main form of donation is knowledge and not money. So global subject matter experts share their experience with the local surgeons in managing traumatic war injuries, and so that the local surgeons can implement into day-by-day case they face. This is also a project we did mainly through leveraging the private healthcare sector in Dongola, the northern state, to serve this place. This is also an example of localization of aid. So instead of doing the traditional healthcare projects, setting, for example, mobile clinics, which is very costly, we shifted into using the already existing private healthcare so as to provide health to those displaced in Dongola. So this is provided a very rapid response. We haven't had to wait till we import medical supplies or medications or having our health staff into Sudan. It's just using those already existing doctors so as to provide care and also purchase medications from already existing local markets in the area. So thank you very much. I hope I haven't had very much time. This is my email, muhammad.almahal@sama.sd.org, and this is our website if you want to take a look and support our efforts in Sudan. If you have any question, please, Sarah.
Thank you very much to both you, Mohammed, and to Hashim for highlighting these important issues and also to bringing your own personal experience to this presentation. I see one question in the Q&A, but just before that, Mohammed, your last slides were really eye-opening for us, that you actually do also these things yourself from Sama. Just give us like very quick examples of other programs that you have done before, like concretely, just like, you don't have to go into great detail, but just like things, for example, because this is actually a very important aspect of Sama. I know that you've done a lot of, knowledge exchange with Sudanese doctors who were abroad and who come back to train doctors in Sudan. So just very briefly, it doesn't have to go into very deep detail. And then I will open the mic for Pam Delarji. I hope I'm pronouncing your name correctly, and then she can pose her question herself. If there's anybody else who has a question, just type in the Q&A box your question, and then I will open the mic for you so you can actually ask it. Mohammed.
Okay, thank you, Sarah. So, yeah, briefly, um, in SAMA, we have been working into three main focus areas. The first one is feeding, and this has been in the White Nile state mainly, and also Jazeera before the last attack in the Jazeera area. So we work in the White Nile and Sinnar, and the model, as I've said, is mainly through collaborating with local partners who identify as reliable and then provide funding to who can implement the projects. The second thing is the healthcare, and this is mainly through leveraging the private healthcare sector in Northern State, and also to bring doctors from US trained doctors into Port Sudan. And we have did this for the last in the last maybe before 2 weeks. We have Dr. Amir Al-Hassan who have been traveling to Port Sudan, carrying with him medical supplies and medications which have been distributed into the local hospitals in Port Sudan. And also he provided in-person training and teaching for the local doctors and health professionals there. So this is the second thing. The third thing is using the virtual learning model to connect those on the ground with the global expertise. And this really maybe, if I have to say, this is the most successful one, because it really cost us maybe let's say zero, because just the running cost of the center in Port Sudan, but no other cost. The subject matter experts who are already Sudanese medical doctors who wanted to give back to Sudan, so they don't charge us anything. And the local surgeons, they already need the knowledge and the skill, because senior doctors have been fleeing out of Khartoum, leaving those junior doctors alone. So they needed this kind of support in their day-by-day operation. So this is just very briefly. I will put the website in the there's a chat box, right? I can't see it. Yeah.
No problem. I will, when we send out the recording of this webinar, I will include your information, and I will also send you other information, because the Royal College of Surgeons was recently doing such an evaluation of actually innovative ways to train surgeons. So this is something I will also put you in contact with them, maybe, because they can. Maybe you can reach out to them for additional information. Thank you very much, Mohammed. Okay, I will move to Pam. I will. All right. So I'm going to promote you to a panelist, Pam. Yay! And then you can actually open your camera and audio and video if you'd like. Thank you.
Thank you. Yes.
Great. Please go ahead. You seem to know Sudan, so please ask your question.
Well, I know a bit about Sudan, and I'm very proud of the work of Sama as well. Thank you so much for for everyone who has spoken so far today about this really, really terrible situation. And I have two questions, I guess. In terms of the barriers for providing support, humanitarian health support, a few things were listed: the difficulty in getting visas, the difficulty in getting supplies in anywhere except through Port Sudan. So my question is this: I do understand the government's security rationale for not opening up borders for supplies coming in all directions. But at the very least, for the government-held areas, it's surprising to many people that they will not allow supplies to come in from the north, from the south, from other places in the east. And I'm wondering if either of the panelists can explain that a bit. And that is also tied to the difficulty of humanitarian organizations to get visas for staff to go in. And is this an issue that we could do advocacy with the Ministry of Health with, or is this a strictly SAF hack decision to restrict this?
Thank you. Hashim, do you feel competent and courageous to take on this this answer?
What can I lose more than this? But I mean, the thing is, it's a military rule, and the military rule not only just being not open for others, but they have this history of being isolated. And one of the things also I believe, suspicious of all the external aid, and they don't have the tools to verify because of lack of competency, uh, adds up to the damage in the way of the system of ruling. But I think there are certain countries that know how to deal with this government. A couple of countries, they know how. So I think the solution will be to go through these countries, and that's how things can come. Egypt, Qatar, for example, are the recent two um, countries that have been working together with the government.
Just reflecting on the visa part, first, hi Pam, I hope you're well. So yeah, for the last mission that we did to Port Sudan, Amir Al Hassan, although he's a Sudanese American, but still having the visa for him was very challenging. We had to leverage multiple connections in US and in Sudan, so as just to give a visa for one person to come to Port Sudan, so as to provide care for people there. So it took a very long time and very long conversations here and here, but finally we got it. But it wasn't easy. I'm not sure what is the problem exactly, but I think as Mr. Hashim said, it is the military rule. We can't expect something else.
Okay, thank you very much for the question and for the responses. I have a question from Reem Abbas. I think, Reem, you can just go ahead and speak. Let's keep it very briefly. Sorry, we have only 2 minutes left in the session. So let's try to get as much as we can in these 2 minutes. Thank you. Go ahead, Reem.
Thank you, everyone. Thank you, Mohammed Al-Mahal. I just have a couple of questions around the challenges of delivering humanitarian aid. So you mentioned accountability and reporting. My question is, are there criteria set for organizations, for local organizations to be reliable? I mean, how do you identify whether an organization is reliable or not? I think it would be very helpful to have specific criteria for this. The other thing is about reporting, which is very important for the donors, of course. So I'm thinking, do we have like standard reporting templates, or is it up to each organization to report in it the way they like? So this would solve the quality of reports. We have to have, our SAMA has to have a standardized reporting templates. And of course, to be able to...
Thank you, Reem.
Yes.
I'm sorry, I'm going to have to interject. Let's see what Mohammed can say, because we really do not have a lot of time, and I see more questions coming in. Thank you. So briefly, Mohammed.
Thank you very much, Reem, for those really important questions. Regarding reporting, of course, the template, each organization have different template, and this might differ from funding partner to another. So yeah, we have templates, but still, still it's challenging. It's still those local organizations may not always be able to fill those templates in a quality way, and this is also what define for us as SAMA the reliability, because those organizations who provide quality reporting on the projects, we classify them as reliable, and we want to build our relationship with them in the future. And those who provide low quality reports, and we identify them as not reliable, and then we shift from them into other partners. We can have more discussion else, because Al-Sara is holding her stick and
Thank you, Mahmoud. I'll get in touch with you. Thank you.
Okay, thank you, Reem.
I'm sorry to be so strict, but I do not want to take more time from people. I just saw a very quick comment in the Q&A, and I would just like to read it out. It's from Mitra Nasih, and she says that my colleagues and I have projects related to health and economic integration among South Sudanese refugees in Uganda. One of the very sad observations we had last summer was an increase in the suicide rate among South Sudanese refugees, and we were told that it is associated with hunger. Thank you for organizing this panel. Thank you, Mitra. And I think that's an important also maybe issue to take into consideration now that Sudan is also threatened with famine. I will forward the questions which are still in the chat box to our panelists, and thank you very much for our panelists. Thank you for the attendees, and we hope to see you again next time. Our next webinar is going to be a unique look into the situation in Myanmar, Burma, for those who know it as by that name, in Myanmar. And as soon as we have a fixed date and flyer, etc., we will definitely get in touch with you and send it out. Thank you very much again, and good evening, good morning, have a great day, have a great evening to all. Bye-bye.